Okay, so the topic that I'm discussing today is pancreatitis. Pancreatitis is basically inflammation of the pancreas. It can be two types: acute, which can be resolved and is reversible, and then chronic, which leads to irreversible damage to the pancreas. And so the treatment therefore is lifelong. So looking at the anatomy and physiology of the pancreas, pancreas is found in the upper part of the abdomen, the right upper quadrant, and it is basically made up of three parts or four parts. You have this flattened area, which is the head that's close to the duodenum. And then you have the narrower part, the body, and it tapers down into the tail that kind of rests right in front of the left kidney. The main pancreatic duct joins up with the common bile duct, and together they secrete bile and the pancreatic juice, which contains all the digestive enzymes, into the mid portion of the duodenum. So pancreas have a dual function: exocrine, which is they're secreting the digestive enzymes through this duct, and endocrine, which doesn't require duct. So those are the hormones that get secreted directly into the bloodstream. So the exocrine function is to digest the food. Bile basically emulsifies or breaks down the fat into smaller particles, and then the pancreatic enzyme like lipase can act on that fat and break it down. Amylase acts on carbohydrates, breaking it down. Trypsinogen and proteases act on proteins and break down proteins. So the food that enters from the stomach is primarily acidic, and so the pancreatic juice is alkaline, so that tends to neutralize all that acid and protects the lining of the intestine. The exocrine function, the cells, the endocrine cells, secrete all the hormones like insulin and glucagon, which are needed for glucose regulation. The main function of insulin is to take glucose from the blood and then transfer it into the cells, and then glucagon helps in stimulating the liver to break down glycogen into glucose when blood sugar is low. There are other hormones in the endocrine cells of the pancreas, like somatostatin, which basically it delays the emptying of the contents of the stomach, the gastric contents, so as not to cause spikes in blood sugar and blood glucose. And then you also have another hormone called ghrelin, which stimulates the hunger pangs. So as I mentioned, there are exocrine glands, which is kind of the darker stained glands that you see here, or cells rather, and they're referred to as the acinar cells. They have all these ducts, so it's these accessory ducts that join up with the main duct. You can think of them as being like the tributaries, and the main duct, the pancreatic duct, is the river. So this is where all the digestive enzymes and the juice, pancreatic juice, is produced, and then they are transported into the main duct, and then from there they join up with the common bile duct, and then they are transported into the duodenum. Now this area is known as the islets of Langerhans. Kind of looks like an island. That's where the endocrine cells are located, like the alpha, the beta, the delta cells, and the epsilon cells. That's where the hormones are manufactured. and the hormones are the major hormones. The majority of the cells, 80%, is the beta cells that produce insulin, and then 30% is about 20 to 30% is about the glucagons producing alpha cells. So pancreatitis is basically inflammation of the pancreas. The mechanism is not all that well understood, but basically it's the pancreatic duct that becomes obstructed, and it kind of leads to a buildup of now the enzymes, because they're not able to enter the duodenum, and so they get activated from the bile coming through the bile duct. And so literally what happens is there's kind of like a reflux, and that leads to those enzymes destroying pancreatic cells in the pancreatic tissue. That's acute pancreatitis, which again can be resolved. But if it is recurrent, then it kind of leads to damage of the pancreas, which can be permanent and irreversible. And once that happens, because there's not the digestive enzymes that are reaching the duodenum, and insulin is not produced in sufficient quantities, it can lead to diabetes and malnutrition. So again, the blocking of the ducts is thought to be because of the presence of these gallstones. Is basically the hardening of the bile. Bile contains cholesterol. It also contains bilirubin from the breakdown of red blood cells in the liver. And so the hardening of those can lead to the formation of gallstones, which then prevent the bile and the pancreatic juice and the juice containing the digestive enzymes from reaching the duodenum. Sometimes some of these accessory ducts can also get blocked because of the presence of calcium stones, calcified proteins. And when that happens, it can lead to the atrophy of that acinar cells. And that is again a kind of cell death. And frequently we hear the term necrotizing pancreatitis. That means when there's tissue death. And so portions of the pancreas have dead tissue, basically. So acute pancreatitis typically might develop in midlife. Risk factors: alcoholism. So alcohol, the exact mechanism again is not known, but it probably is thought to kind of make the pancreatic juice more viscous, thicker. It also stimulates this gallstone formation. And so when those ducts are either damaged or blocked, then the pancreatic enzymes kind of end up digesting or auto-digesting the pancreatic tissue. Also, there is a buildup of fluid in the interstitial spaces between the cells. So pancreatitis can lead to dehydration, severe dehydration, because there's literally the fluid from the cells is getting into those interstitial spaces. Again, mild forms of pancreatitis like acute pancreatitis can be reversed. However, if there has been frequent attacks, then it leads to necrotizing pancreatitis, which is irreversible because it leads to cell death and damage of the pancreatic tissue. So chronic pancreatitis follows several acute pancreatitis attacks. Alcoholism, chronic alcoholism is the primary risk factor. In this case, lifelong treatment would be required. The ducts, it might even require surgical intervention to get rid of all the blockages. It's a progressive condition which is irreversible. The patient loses a lot of weight. There's severe weight loss, can become anorexic, and then because the acid, there's nothing to counter the acid, since the stomach contents are acidic, and because the pancreatic juice is typically alkaline, so it can lead to the formations of peptic ulcer. So the clinical manifestations for uh, acute pancreatitis is that severe epigastric pain that radiates to the back. There's a lot of nausea, vomiting, buildup of fluid in the stomach, so that will be manifested as decreased bowel sounds. Pancreatitis leaves the patient vulnerable to infection, so might see low-grade fever, and then there's loss, blood volume loss, the hypovolemic loss, and then increased heart rate, so the hypotension is seen, cool clammy skin, elevated WBC, serum amylase and lipases are again markers that are elevated, indicating pancreatitis. Hypocalcemia, hypomagnesemia also is seen. Persistent recurring episodes of pancreatitis will lead to weight loss, the anorexia, constipation, and then the fat in the stools because the fat is not getting digested, and then elevated glucose in addition to the elevated amylase and lipase because there's not enough insulin to lower the glucose. Some of the assessments, what to look for, the subjective data, of course, is the pain that the patient will report, including the nausea, vomiting. Objective data is to look for signs of dehydration, the abdomen showing fluid buildup in the abdomen, the hypotension, the bruising in the flank and around the umbilicus region, and the lab markers are the lipase amylase levels. Rate the pain, document the medication list to see if some medications like the cholesterol medications and birth control can also lead to adverse effects like affecting the pancreas and the pancreatitis. And so look at what the patient's diet, analyze those lab results. As I said, amylase and lipase are markers, also amylase in the urine. Calcium and magnesium are very low. Elevated WBC indicates that there is inflammation or infection. To distinguish between inflammation and cancer is to look for this particular marker, which is the carcinoembryonic antigen. If it is elevated, that's an indication of pancreatic cancer. Now, frequently what happens is if the chronic pancreatitis is not properly addressed, it can lead to pancreatic cancer. Diagnostic ways to determine if there is pancreatitis is to check with x-rays, ultrasound, the CT scans to see, and this is a technique called as ERCP, which distinguish between acute and chronic, because if there's irreversible damage, that indicates chronic. Also, there is a buildup of fluid, as I mentioned before, and that leads to formation of these cysts. So removing a small sample of those cells from those cysts can be tested for cancer to see if they're cancerous. And so there is a lot of complications associated with pancreatitis, including the pseudocyst, infection, kidney failure, breathing problems, uncontrolled blood sugar, diabetes, especially malnutrition, and then long-standing inflammation leads to this chronic pancreatitis is a risk factor. Now, this is not a concept map that I made. I have to give credit.